Okay, good morning. Can you hear me? Is it working? Yeah. So our next lecture is a lecture on novelties in oncology clinical trials in the molecular era. And this is going to be given by Dr. Jean-Charles Soria. And I will let Dr. Ziede introduce him to you.
Yeah, good morning. I realize we are late, so I promise to deliver this talk in 15 minutes.
Yeah, I just want to say a few sentences about yourself. Thank you very much, Professor. Jean-Charles Soria is Professor of Medicine and Medical Oncology at South Paris University. He's obviously trained as a medical oncologist. He's chair of the Drug Development Department at the prestigious Gustave Roussy Cancer Center, and is member of the Lung Cancer Unit. He's also editor-in-chief of Annals of Oncology. His main research, other than lung cancer, is phase 1 trials across many solid tumors, pharmacodynamic markers, and personalized medicine. So welcome, Dr. Soria.
Thank you very much. It's an honor to be here. I probably represent here the protege of Fadlo, not a mentor, but a protege. I happen to work in MD Anderson under Dr. Ki Hong leadership, but you know, Dr. Ki Hong was already a king, so it was not easy to be the postdoc of the king, and you need an intermediate level, and that level was offered to me by Fadlo Khoury, who has remained not only a role model in my career, but also a true friend, and I can, you know, here tell you that what you have heard about him, about his honesty, about his kindness, about his willingness to promote others, is pure and true reality. I owe him part of my career, and I'm happy to be here. I'm also happy to be here as the only French representative in this country that is so close to the heart of French people. So without more, so without delay, I was asked by Fadlo to give you a talk that will maybe illustrate how quick the world is changing and the landscape in oncology is it's being modified at an unprecedented pace, not only because of genomics and precision medicine, but also because we have new therapeutic possibilities, including immuno-oncology. So this is what I'm going to try to do. First, tell you in a nutshell what are the changes in the classical drug development paradigm. Second, what are the reasons for these changes? And third, what are the challenges that these changes pose in front of us? So what are the changes? Well, maybe or maybe not, but if you look in the textbooks, classical drug development paradigm before 2000 was characterized by 3 main phases. Phase 1, who was supposed to be the tolerability phase 1. Small number of patients, 20 to 60. Registration value, null. It was followed by phase 2, which was a confirmatory trial in around 100 patients to confirm response rate, followed by phase 2, which was randomization with the standard of care, which usually take hundreds, if not thousands of patients, and that's where the registration value was. Well, if you have not followed the literature and presentations recently, I'm sorry to say that phase 1 has swallowed phase 2, and the change is really profound. Phase 1/2 now is seeking both at defining the maximum tolerated dose and activity. Therefore, the emphasis is no longer only on safety, but also on activity and biomarkers. The endpoints will encompass toxicity and response, and this is why now you have phase 1s that can go up to 1,000 patients. And it's not a single case. There are 7 cases of phase 1s that have more than 1,000 patients. So this is an important transformation in the way we are doing drug development. And the registration value is true. 6 drugs have been registered on the basis of phase 1/2 data, no longer phase 3. Of course, it's a conditional approval, but this is completely new. And of course, phase 3 remains necessary as the major confirmatory trial. So this has implications, both in terms of the median duration from which we can register a drug. Usually it has been 8 to 10 years for a cost of 1.8 billion. Huge. Well, now we have examples where with the new paradigm of drug development, we can shorten that to 5 years, or even the latest EGFR inhibitor of AstraZeneca did it in 2.5 years. So hopefully this is going to not only shorten the time, but hopefully it's going to shorten also the cost. Why are we seeing this change? What is new? Well, what is new is, first of all, that biology, and I'm sure Professor Meyerson is going to give you an inspirational talk, we are making this change because we understand better biology, and we better match the therapy to the reality of the tumor in terms not only of the clinical characteristics, but also the molecular circuitry that is undergoing. And by genotyping, we have moved in phase 1 trial from classical response rates that used to be 10% to response rates that are usually above 30%, if not even above 50%. So in this true mechanism-based approach, which is both oncogene de-addiction and synthetic lethality, we have gained a lot of activity. And this is leading to the fact that the classical design of dose escalation, 3+3 patients, followed by a small expansion, has been modified by dose escalation, followed by expansions in molecularly enriched patients. Crizotinib was the first example. It took 5 years from the initial first-in-man trial to the approval by FDA that was based on phase 1 and phase 2 data that encompassed at overall 250 patients. But we have now the third-generation EGFR tyrosine kinase inhibitors. So this is a target in lung cancer, notably never smokers. And it's a small target because if you think in the Caucasian population, EGFR mutation is 10 to 15%, 60% of those acquire a resistant mechanism. That makes that these third-generation EGFR TKI inhibitors have been developed only for 6% of all Caucasian non-small cell lung cancer. And this was the initial design of the AZD9291 or osimertinib compound. You see, it was written in 2013 to be a trial with a dose escalation in 66 patients and an expansion in 92. What happened in the reality is that activity was at the rendezvous, and therefore, expansion cohorts kept on going, were tested at multiple dose levels, and it was even tested in first-line patients. So at the end, we had a phase 1 with 556 patients with a response rate of 66%, much better than a standard chemotherapy. This is going to accelerate because we have a surrogate for tissue that is not perfect, but it's improving, and it's the liquid biopsy. We can fetch mutations in the blood. We can find amplifications in the blood. And hopefully one day we will also be able to find translocations in the blood, maybe by the analysis of exosomes. The other main reason for the change is the advent of immuno-oncology. So we spent billions of dollars for no use in immunotherapy because we were trying to activate the activators when the problem was to take away the brake from the inhibitory signal. However, immuno-oncology is transformative. It is transformative because we don't need to hit the tumor every single day or every single week, contrary to chemo or targeted agents. We just need to awake the dormant army of lymphocytes that are in our body. And this is going to question for how long we need to give these drugs. I am not a believer of nivolumab forever. I think probably 6 months, 1 year, to kick the system in is probably enough. But anyhow, because these drugs are transformative, you need to be aware of that. And most of the publicity has been on the checkpoints that are inhibitory receptors on the T cells. But the wave that is coming in is huge. It's going to concern also activating receptors in the T cells and in other immune cells. To give you an idea, I told you that with genotyping response rate was increasing to around 30%. I look at what was happening in our phase 1 program at Gustave Roussy with immune checkpoints. So from 2013 and 14, 184 patients were enrolled in phase 1 trials. In those patients, 2/3 got a benefit, 30% shrinkage, defined as a PR by RECIST, and 53% stable disease, so significant transformation. The other important element you need to know about immuno-oncology is that the spectrum of activity is extremely large. Although it is not addressing 3 out of the 4 main killers, no activity in prostate, nor in colorectal except MSI, nor in breast except triple negative, is still transformative because you can see here that the spectrum of tumor in which it has activity is huge. And because of this, we have seen the other profound change in phase 1 design, because here we don't need molecular enrichment. We need expansion cohorts in defined tumor types where we have activity. And this has moved phase 1 not from a few tens to hundreds, that was the case for targeted agents, but to thousands, because we have these expansion cohorts in different tumor types. If you don't believe me, look at the numbers. This is the phase 1 trial from atezolizumab. This phase 1 trial is still ongoing. I called them yesterday, they were above 500 patients. It's still ongoing. The phase 1 trial from pembrolizumab, which is a registered compound, initially was planned as a 32 patients phase 1 trial in 2011, and in fact, it enrolled over 1,260 patients. The other reason why we see these changes is the open approach of regulators. This is mainly led by FDA, but also to some extent now by EMEA. So FDA has been providing breakthrough designation based on phase 1 trial results. This was the case for osimertinib and ruxolitinib in EGFR mutant patients. This was the case also for atezolizumab, who got a breakthrough designation only in 70 patients with bladder cancer. But we saw FDA conditional approvals, accelerated approval for crizotinib, accelerated approval on phase 1/2 for seritinib, both less than 5 years as the first patient was enrolled in the corresponding phase 1. And now in November 2015, we saw FDA granting approval to osimertinib less than 2.5 years from first patient enrolled in the first in-man phase 1. So what challenges do we have if we keep on keeping this trend? Well, one of the challenges we're going to have is toxicity. Phase 1s have been defined to read out toxicity based on what we call the DLT, dose-limiting toxicity, which is to be evaluated during cycle 1. For immuno-oncology, that's not adequate because most of the side effects happen later on in cycle 2 and in cycle 3. So we might have problems there. We need to keep that in mind. Second, for immuno-oncology, we are not doing our best job because, first of all, we have no dose relationship with activity. We don't know what is the optimal direction. We don't know what is the optimal route. In fact, we have as much activity with nivolumab at 1, at 3, or at 10 milligrams per kg. This is also the case for pembro and atezolizumab. I believe we shall be using maybe these monoclonal antibodies as vaccines with a limited number of boosts and a rechallenge as PD rather than spending $17,000 per month forever. Finally, you need to be aware that the tsunami is huge. It is huge. I refer to checkpoint inhibitors for T cells, but full development is ongoing for checkpoint inhibitors in macrophages as well as in other components of the immune system. We have to be ready for CARs, and we have to be ready for bispecific antibodies. And of course, this is going to be a fantasy because we will be able to combine immune checkpoints with chemo, with targeted agents, with radiation therapy, with other immune checkpoint inhibitors. So this is one of the slides to illustrate that what I have said is not just a vision of my mind. We have had registration on phase 1 for pembro, seritinib, crizotinib, osimertinib, and others. And therefore, this is my last slide. We have moved in the last 10 years from, trials based on cytotoxic compounds that were enrolling 30 to 50 patients to trial with molecular target agents enrolling hundreds of patients to immunostimulatory agents that enroll in phase 1 thousands of patients. We moved from IV to oral, and we are going back now to IV, but maybe intratumoral or subcutaneous will also be a route of administration. The relationship between activity and toxicity was pretty clear for chemotherapy, challenge for targeted agents, and is really not clearly present for immunostimulatory antibodies. The design of the trials has changed, and the approval is no longer in phase 3, but can also happen in phase 1, leading to registration in less than 5 years. Thank you for your attention.
Thank you, Dr. Soya. In the interest of time, we're not going to have any questions for this session, and we will move to the next one.
Drs. Arafat Faili and Dr. Jara. Please.
It's my pleasure to introduce Dr. Ramalingam. Dr. Ramalingam is a well-established researcher in lung cancer, and he is a professor at Emory University. On a personal level, I got to meet Dr. Ramalingam during a trip to Emory in 2010. It's not working. And I was quickly impressed with his excellent patient care and his dedication to breakthrough research. So really, it's a great pleasure to have you at AUB today, Dr. Ramalingam. And his presentation is about small cell lung cancer.
Good morning. So as I talk, I wanted to let you know of a small change in the agenda in that since it's a debate format, Dr. Curry, myself, and Dr. Bunn made this a little more interesting by splitting the topic into my discussion focused on the role of cancer cooperative groups in lung cancer, and Dr. Bunn is going to talk about the role of cancer centers in improving the outcomes for lung cancer. So as I talk, I wanted to first start off by saying it's a tremendous honor to be here at this important occasion in AUB. I want to congratulate Dr. Curry for becoming the 16th president of AUB. I've had the distinct pleasure of working with Fadlo for the past 8 years and have got to know him in various roles as a leader, as a physician, as a teacher, as a mentor, and more than everything else, as a friend. And I know that the institution is up for significant milestones in the next several years under Dr. Curry's leadership. I also want to, on behalf of Emory University, congratulate AUB on its 150th year. Having sat through and heard about all the accomplishments of this institution in the past 2 days, and also listening to Dr. Curry's vision for the future, I am convinced that AUB is not only making history, but you're actually making history proud. So let me start by saying lung cancer is a very different disease in 2016 than it has been over the past 2 or 3 decades. We now can detect lung cancer early, at least in a subset of patients, and we can offer them curative therapies. We also know that lung cancer is no longer one disease, but is comprised of diseases with varying molecular phenotypes and genotypes that can be distinctly targeted with various approaches. And we have learned that targeted therapies, at least for a subset of patients with lung cancer, results in improved outcomes. As Dr. Soria pointed out, immunotherapy is already becoming an effective tool to manage patients with lung cancer, and individualized therapies are now being extended to the curative settings from more palliative treatment approaches. And I'm going to make the case to you that the cooperative groups have led the way in ushering in new treatments for patients with lung cancer, as they have done for various other cancers as well. And I was pleased to hear the plans from AUB Medical Center and Cancer Center to establish cooperative groups in the region and also to participate in global groups to lead outcomes for patients with cancer. Now, we now know that by using CT scans in patients with or subjects at higher risk for lung cancer, we can actually detect lung cancer early and reduce lung cancer-related mortality in about 20% of the patients. These CT scans are done in patients in the 55 to 75-year-old age group, smoking history of 20 to 30 pack years, and by doing annual CT scans over 3 years, you are able to detect lung cancers early. And in fact, when you detect lung cancer early, nearly 80% of them will have early stage disease, so you can offer them surgery or combined modality therapies that have resulted in curative outcomes. And this trial was conducted, sponsored by the NCI, by the ACRIN group, which was a cancer cooperative group or an imaging cooperative group, now part of the ECOG ACRIN Cancer Research Network. Now, Dr. Brawley is going to talk a lot about screening in lung cancer and beyond in the talks to come. But I just want to make the point that we now have a tool to detect lung cancer early, if not in everybody, at least a subset of patients, and be able to offer curative therapies. Now, not every patient with lung cancer can undergo surgical resection. In stage 3 disease, in fact, we have a substantial majority of patients who cannot have surgery. And for those patients, chemotherapy with radiation results in improved cure rates. About 20% of the patients whose tumors cannot be removed by surgery can, in fact, be cured by giving chemotherapy with radiation. And this was proved by the RTOG phase 3 trial 9410 that showed improved survival and a 5-year survival rate of modest 20 to 25% in this patient group. Now, for the past 10, 15 years, our radiation colleagues have been firmly of the opinion that higher radiation actually cures more cancers. And these were all based on single institution phase 2 studies that showed that if you give 74 gray of radiation to patients with stage 3 disease, you may actually cure more patients. Well, this is why we do clinical trials, my colleagues. This is the RTOG trial that showed that when you compared conventional 60 gray of radiation to 74 gray of radiation, the 74 gray of radiation arm was inferior to the standard radiation approach. So we do not recommend high-dose radiation, and this is a trial that came out by a combined effort of the US cooperative groups led by the RTOG group. How about patients with resectable lung cancer, where surgery results in cures? Even there, despite complete resection of the tumor, cure is only achieved in a subset of patients. For stage 1 patients after surgical resection, cure is only seen in about 60 to 65% of them. We now know that by giving chemotherapy, platinum-based chemotherapy, after surgical resection, you can provide a modest improvement in cure rates. And that paradigm was also ushered in by cooperative group trials done across the globe, spanning from the US, Europe, and even in the Far East. And these are examples of clinical trials that showed that survival can be improved with adjuvant chemotherapy, which is now the standard of care for patients with either a large primary tumor greater than 4 centimeters in size or a node-positive lung cancer that has been completely resected. Well, in stage 3 patients, in fact, not all patients need surgery. There are patients who can get similar benefits with chemotherapy and radiation as those who receive chemotherapy radiation followed by surgery. In fact, for some patients, the trimodality approach where chemotherapy and radiation are given and then surgery is done, you may actually see an improved or increase in mortality. And this trial, RTOG and intergroup trial, showed that chemotherapy and radiation is just as effective for stage 3 disease. Again, showing that the cooperative group efforts have advanced the care of every single stage of patients in the early settings. What about advanced stage disease? We know that chemotherapy improves survival, chemotherapy improves quality of life. This is the landmark trial by ECOG, which almost 15 years ago now showed that various chemotherapy regimens, in fact, 4 different chemotherapy regimens were used, and they had similar outcomes. Now, the outcomes here were modest, at that time represented incremental benefit over supportive care, but we now know that chemotherapy can be improved and can be substituted with targeted therapy in some patients who have molecular targets. This trial shows the ECOG 4599 clinical trial that showed that adding an anti-angiogenic drug to chemotherapy results in improved survival in stage 4 disease. And this study led to the approval of bevacizumab, which is a monoclonal antibody against vascular endothelial growth factor that is responsible for growth of new blood vessels to the tumor. Targeted therapy is now a reality for lung cancer. About 15% of patients with advanced non-squamous or particularly adenocarcinoma histology will have the EGFR mutation. And this is the Japanese trial, Western Japanese cooperative group, that showed that giving an EGFR targeted agent is superior to chemotherapy for patients who have the EGFR mutation. And this and several other contemporary studies have now led to testing for EGFR mutation as a critical component of diagnostic workup for a patient with newly diagnosed lung cancer. In fact, we test patients for a number of molecular abnormalities at the time of diagnosis of lung cancer, so as to see whether targeted therapy can be used for those patients. And if they are not candidates for targeted therapy, we now give chemotherapy, and soon immunotherapy is knocking on the door, and it's likely that in the next 2 years, we might be replacing chemotherapy with immunotherapy for a substantial proportion of patients with lung cancer. This is a study that we have just completed at the Eastern Cooperative Oncology Group, where we have compared 3 different maintenance approaches. This is therapy that comes after standard chemotherapy, and this paradigm, maintenance therapy paradigm, was ushered in the year 2007 and 2008 with approval of 2 different agents, bevacizumab, pemetrexed, and erlotinib being the maintenance therapy drugs. And ECOG has enrolled more than 1,500 patients to this phase 3 trial, where we're expecting the results to mature in the next upcoming months and show which maintenance approach is associated with the best survival impact in stage 4 non-small cell lung cancer, thus helping define a new paradigm for maintenance therapy. Now, finally, we are moving these targeted approaches to curative settings. This is the signature initiative of the National Cancer Institute in the US, referred to as the Alchemist program, where various cooperative groups have come together to evaluate targeted approaches in early-stage lung cancer patients whose tumors are defined by specific molecular aberrations. For instance, a patient with an EGFR mutation in this study will be randomized after surgery and adjuvant chemotherapy to an EGFR inhibitor versus placebo. Similarly, a patient with an ALK-positive disease will be randomized to crizotinib versus placebo. And we're soon to add a 3rd arm, which will incorporate immunotherapy for patients who do not have EGFR or ALK in this setting. And this will help us show if targeted therapies indeed improve outcomes or survival outcomes and cures for patients with lung cancer. In squamous cell lung cancer, where molecular targets are beginning to be learned, characterized, there is a large ongoing national effort in the US looking at various molecular subsets and targeting or tailoring therapy based on the molecular subset. This is referred to as the Lung Map study, which is in the year 2 of its inception. So I want to conclude by saying that while outcomes for lung cancer have steadily improved in the past 10 years, the cooperative groups have played a major role in defining these new treatment paradigms. And the group conducts studies that cannot be answered or will not be answered by any other mechanism, particularly by industry, where trials are driven by bringing drugs to market, not necessarily to define what's best and what's the most cost-effective approach for treating that particular cancer. And I would also want to echo the sentiment made by the career development speakers that mentorship is a critical part of involvement in the cooperative groups, and cooperative groups have paved the way for development of careers of a number of outstanding investigators, many of whom are here in the audience today, that will define in the future new treatment approaches for treating lung cancer. So I want to thank you for the opportunity and have a great day.
Thank you, Suresh. And it's my pleasure now to introduce Dr. Ban. It's really we are privileged to have him with us. I don't know if you can. Dr. Paul Ban is director, is Distinguished Professor James Dudley Chair in Lung Cancer Research, is director of the University of Colorado Comprehensive Cancer Center, and is involved in many programs in research in lung cancer, diagnosis, preventions, and treatment. Today, he'll be giving us the counterpart of research that takes place at cancer centers versus that of this takes place with cooperative groups that was presented by Dr. Suresh. Thank you, Dr. Ban.
Thank you. I'd like to thank the organizers and Dr. Curry for inviting me to speak. In 1971, the National Cancer Act was passed by the U.S. Congress, and that set up regional cancer centers throughout the United States. The goal was to improve cancer education and reduce cancer mortality. And so there are regional cancer centers around the country. From my perspective, the Emory Cancer Center was not one of the most prominent until Dr. Curry came along. And I'm not as good a speaker as Dr. Curry, but I show this because people always think of Italians and women as being much more expressive. But I like Dr. Curry's hands here. It's very telling. even though he's younger than I am, I consider him a mentor. So I'm going to focus on two treatments, molecular therapies and immune therapies, because I don't have a lot of time. But in 1971, people thought that the National Cancer Act was going to cure cancer by 1980. And of course, that didn't happen. And it takes much longer than people want. But the fact is that effort led to 7 new drug approvals in lung cancer in the last year, shown here. And essentially, all of these 7 drug approvals were based on studies that were conducted at major cancer centers. So one of the things that happened in molecular therapy was that we could measure multiple abnormalities, molecular abnormalities at the same time. And so a group of US cancer centers funded by the NCI got together and formed the Lung Cancer Mutation Consortium and decided to test 10 oncogenes at the same time. And these are the 10 that were tested, and these are the fraction of patients that had each of these molecular abnormalities. Now, many of them were not all that common, and interestingly, very infrequently did people have more than one of these molecular drivers. Now, up until this time, the median survival from chemotherapy, as you saw in the previous speech, was 6 months. And with chemotherapy, that improved to 1 year. But look at the red curve, which is those patients that had a molecular driver and received an oral tyrosine kinase inhibitor, with a median survival of almost 4 years. Now, the black line is people that had the molecular driver that did not get an oral therapy. Now, these patients are not cured, but you can see the dramatic improvement in outcome for those that have a molecular driver and get an oral agent. So how does this work? Well, the work preceding this showed that when you have a growth factor and it binds to a growth factor receptor, in this case a tyrosine kinase inhibitor, there's a change in the conformation that allows ATP to bind, and ATP transfers a phosphate group to a cancer protein, which activates it. And so drug companies with three-dimensional structure could design drugs that fit into the ATP binding pocket, preventing ATP from binding. And when that happened, you would inhibit the cancer growth. But they also realized that once exposed, the cancer cells are smart and would mutate and develop a new resistance mechanism where the TKI could no longer bind and ATP could outbind the tyrosine kinase inhibitor. But we knew the structure of the mutated receptors well and could develop third-generation drugs that would bind to the secondary mutation pocket. So in EGFR, which is one of the major drivers, one of the gatekeeper mutations that prevents the binding of the new drugs is called T790M. And when that mutation occurs, interesting, the cancer cells grow more slowly, but this causes resistance to the original tyrosine kinase inhibitor. And so osimertinib, that was described by Dr. Surya, came along, and that could bind into the T790M binding pocket, another oral drug. Interestingly enough, as this drug was developed in phase 1, patients responded at the lowest dose, and they responded all the way up to the highest dose given, 240 milligrams, and the maximum tolerated dose was never achieved. And so how to proceed? The company decided to proceed with 80 milligrams, but this drug was approved in 2.5 years from conception. Another driver oncogene is called ALK. And for ALK, which occurs in only 4% of the patients, crizotinib was originally approved. More recently, major cancer centers have been studying the second and third generation ALK inhibitors shown here. 2 of them have already been approved, ceritinib and alectinib. Brigatinib has accelerated breakthrough status from the NCI, and the newest drug is under phase 1/2 development in cancer centers. Now, one of the questions about these drugs, will they be better than the original drug? And the original drugs don't cure patients. The average time to progression is about a year for the original drugs. However, one can stay on those for up to a year and a half. And now we have the second generation drugs, and they have a median progression-free survival of 10 months. And the question is, will these new drugs be better? And so this is one of the newer drugs, and the progression-free survival in patients was 28 months, and the 2-year survival rate was 80%. And so now we have randomized trials to determine whether these new drugs will improve the overall outcome. One of the major advantages of these new drugs is they cross the blood-brain barrier. And one of the places where the patients fail with first-generation drugs is in the brain, because most of them do not cross the blood-brain barrier, but these new drugs also cross the blood-brain barrier. So what have cancer centers done with the immune system? We now know that tumor cells develop proteins, in this case PD-L1 and PD-L2, that send a negative inhibitory factor to T cells. So the tumor cell prevents the immune cell from killing them. And so these antibodies, these new immune checkpoint inhibitors, block the interaction between the tumor cell and the T cell, allowing the T cell to kill the cancer cell. And so cancer centers are essentially responsible for the clinical trials comparing these immune checkpoint inhibitors, in this case nivolumab, to standard chemotherapy. And you can see not only is the survival improved, but many patients survive for more than 2 years, even after failure of chemotherapy in the second-line setting. This is true for many of these checkpoint inhibitors. This is pembrolizumab, the second one, and it was also shown to be better than chemotherapy. The question is, how do we select the patients that are most likely to benefit? And the target is PD-L1, and so expression of PD-L1 does affect the outcome, and you can see that the patients with the highest levels have the best outcome. Now, these are in patients that failed chemotherapy. And what happens in people who have not had chemotherapy? If you look on the bottom right, you look at people who've not had any prior chemotherapy, and those patients that had the highest expression of PD-L1. So at 1 year, none of the patients had failed. Now, these drugs are now being compared to chemotherapy in the first-line setting, and presumably, although we need the randomized trials, will have a much better outcome than chemotherapy. I think that in the interest of time, I'll stop there. And I would say that the Cancer Center here has the opportunity to join the U.S. cancer centers to provide new therapies to patients in the most expeditious manner. Thank you very much.
We have time for 1 or 2 questions according to the organizers, because this is a very important topic, and we can include the talk of Dr. Soria as well. If anyone from the audience has a question? Sorry, it's here. Dr. Saghir. Microphone, please, to the front. Wait, it's coming.
We definitely heard very nice talks. Now,
We can't hear you.
Cancer centers are important, more important to develop drugs, cooperative groups, because like clinical trials, cancer centers developing drugs, clinical trials by cooperative groups, and we heard the new designs and advances in clinical trials by Roshan Surya. Now, where do you put industry here? Should the industry relationship be stronger with cancer centers as it is with cooperative groups, or what is your view on that?
So while I said that those trials were conducted at cancer centers, someone had to fund them. The National Cancer Institute provided some of the funding and funds the cancer centers, but most of the clinical trials are funded by industry. And there are many rules to prevent conflict of interest. But certainly this cancer center, like any cancer center, will have to deal with industry because industry is not the enemy. Industry is a partner. And industry-academic collaborations are extremely important. So I would say that this cancer center should be developing relationships with industry. They should develop conflict of interest rules, but industry is not the enemy. Industry in general is a partner. And partnerships between cancer centers and industry are incredibly important.
And I completely agree with Paul, and even at the cooperative group levels, interactions and partnerships with the industry are critical. Many of the trials that we discussed this morning and many ongoing trials that we haven't talked about involve participation from industry, either in providing drug for the trials or in providing support to conduct translational studies and so forth. So clearly these interactions are important and have to be appropriately managed.
The final comment is the drugs are provided for free in these studies, and so it's one way for patients to get access to very expensive drugs, which is a huge issue here and around the world.
Last question, Dr. Karam.
My name is Karam, and this is not a question actually, it's an attestation.
Microphone.
In 1997, a member of my family developed lung cancer. And it is on the advice and continuous help of Dr. Fatma Puri that she is still living. It was stage 1. She was operated at American University of Beirut on his advice also, because he wanted to take her to the States. And a year later, I carried a statement he whispered in his own way in my ear saying, no one should smoke. A year later, as a Minister of Health, and as a member of the Executive Board of the World Health Organization, and as a chairman of its annual conference, I carried his statement to the podium of WHO, and I insisted on having smoking as the #1 item to be fought by the WHO ahead of other items that other members of WHO wanted to have, like breastfeeding or like fast foods or whatever. And later on a visit to Washington, D.C., and in the office of my friend then, the Secretary of Health, Education and Welfare, Mr. Tommy Thompson, he said, I will give you my chair as a Secretary of Health Education in the United States just for a few minutes, and then take any decision you would like to take. So I took his chair and I wrote on a piece of paper, ban smoking. Now, unfortunately, it did not happen. Just to remind you also that the year 2000, when I was at WHO, Lebanon could get the first prize in fighting smoking, and the declaration that was taken at WHO was signed by Lebanon at that time. And now, as the president of the university, I would urge Dr. Fadlu Khouri also to keep on the war he started against smoking for the treatment and cure of lung cancer. Thank you.
I must say, when I arrived here, I was surprised at actually the amount of smoking. And my first thought was, Fadlo has a job cut out for him to increase the tobacco tax and decrease smoking in Lebanon.
Tobacco use, the leadership role in using the healing water researchers. We also realized that the campus was completely tobacco free by December 31, 2017. So we'll get that out again.
Any public place is next, Fadlo, besides the university.
Well, they'll go smoke on the street. Do the same thing they do with cats, which is go along campus, but at least the campus.
Okay. Thank you. For the sake of time, we're going to move on with the next session, and I think this session probably is going to be very interesting because of two new things that are happening. One, a very recent recommendation by the United States Preventive Service Task Force and the American Cancer Society concerning breast cancer screening that may change the face of screening for breast cancer. And two, a very recent trial that was published and everybody was waiting for, which is the United Kingdom UK-CTOC trial on screening for ovarian cancer. And we're going to hear some prominent speeches among this. Naji will introduce our first speaker.
Yes, actually the first speaker needs no introduction. Oris Brawley, a good friend of ours, of Fadlu, a friend of Fadi Jara. He introduced us, Oris, Chief Medical Officer of the American Cancer Society in Atlanta, Georgia. Oris, everybody knows you. Why don't you go ahead for the sake of time? Dr. Otis Brawley.
Well, thank you. Thank you. It's a pleasure to be here with Fadi, Naji, Ali, good friends, my dearest friend Fadlo. I'm one of the original FOFs, I guess. It's wonderful to be here. Actually, we were here in this room for the opening of the Nabil Cancer Center a few years ago. This one, great. I'm going to talk over the next 8 minutes or so about breast cancer screening. I'm a medical oncologist and an epidemiologist by training. First, I want to note that cancer screening can be beneficial, but it can also be harmful. Many people do not think about the harms that can be brought about by cancer screening. It is oftentimes both beneficial and harmful, and only a good randomized trial can tell you if a specific intervention has a net benefit versus harms. And we're often talking about risk and benefit, or benefit and risk ratios when we talk about screening science. And we do need to follow the science. We as epidemiologists love prospective randomized trials in which groups of people are randomized to half get the screening intervention, half not get it, follow them over time, and see if there's more people alive in the group that got the screening intervention over a period of time. Unfortunately, in an ideal world that can happen, but only in an ideal world. In the real world, you'll have contamination on both arms where people who were supposed to get screened did not get screened, people who were to get screened. And so you have to look at two groups where one group is more screened than another. Now, in breast cancer, mammography has generally been recommended for normal risk women. There's been huge controversies as to whether the age to start is 40, 45, 50, or over, whether we should screen every year or every 2 years, as well as quality of the image and quality of the radiologist. There's also questions about the use of clinical breast exam by a health professional. Problem with screening is screening will miss some disease that we wish we could find, especially among younger women with dense breasts, and screening will find some disease that does not need treatment. That is overdiagnosis. I'm going to talk a lot later today about the fact that there are cancers that don't need treatment. The simple problem with mammography and the female breast is the female breast on a mammogram at the age of 20 is all white. And those of us who are old enough to remember black and white TVs and the contrast knob, remember you turn the contrast knob counterclockwise all the way to the left and it's all white. You turn it all the way to the right and it's all black. A mammogram on a 20-year-old woman is all white, and I'm looking for a white tumor on a white background. A mammogram on a 70-year-old woman is all black, and I'm looking for a white tumor on a black background. And from age 20 to age 70 is 50 shades of gray. I was wondering if that would go with an international audience. It's harder to do a mammogram on a woman who's 40 versus a woman who's 50, and it's harder to do a mammogram on a woman who's 50 versus a woman who's 60. This is not saying that we don't need a screening test for a woman in her 40s. It's to say the screening test that we have is suboptimal. Now, U.S. death rates from breast cancer have gone down by 40% over the last 25 to 30 years. And assessments show that about 40% to half of that decline is actually due to screening. The other half, by the way, is due to improvements in treatment, and a small portion of it is due to the fact that women now feel encouraged or empowered when they're getting dressed or when they're in the shower and they feel a mass to go to the doctor and say, what is this that I feel? But screening is only 40, perhaps 50% of that decline. Now, we at the ACS, under some criticism for how guidelines have been done in the past, they were frequently done by people who had financial interests or people who had emotional conflicts of interest. Now, actually, I've found that emotional conflicts of interest are much more of an issue than financial conflicts. We put together a process, published it in the Journal of the American Medical Association, where ACS staff would commission a School of Public Health to do a systematic review of the science. Then they would write that up, and the guideline or the systematic review for breast cancer was over 800 pages long. It is the world's review. It is a review of the world's literature on breast cancer screening. A group of 15 to 16 experts who do not make their money treating breast cancer, but who understand the screening and treatment issues, would sit down and digest that 800-page document. They would actually meet on a regular basis. They would consult with people who treat breast cancer, people who diagnose breast cancer, people who read mammograms, even breast cancer survivors. And then they would write up a recommendation, and then they would send it into the ACS administration for the ACS to approve the process, but not the guideline. The guideline preface statement is up there. The recommendations are guidance from the ACS for women of average risk for breast cancer. An individual can reasonably reach a different conclusion. The ACS recommends that all women should become familiar with the known benefits, limitations, and potential harms associated with breast cancer screening. This is a guideline that moves away from medical paternalism and moves toward precision medicine. We consider average risk women to be those without personal history of breast cancer, without a known genetic mutation or a history of radiation to the chest for things like Hodgkin's disease. The recommendations were broken down as strong recommendations where there was evidence that the benefits substantially outweigh the risks, and qualified recommendations where there was evidence of benefit, but there was less evidence that it substantially outweighed the risk. And this very busy slide is actually the new American Cancer Society screening recommendation. And that is that we believe that there is strong reason to suggest that women of average risk should start screening at the age of 45. Women who are 45 to 54, we thought there was qualified recommendation, weaker evidence that that screening should be done on an annual basis. At the age of 55, we thought there was qualified data to say that the woman could go to every 2 years if she so chose. We felt there was qualified evidence to say that women 40 to 44 should be informed of the potential risks and potential benefits of breast cancer screening and be allowed to make a choice as to whether or not they want it to be screened. That's perhaps the most controversial element of the guideline. We believe that women should be screened until they had a 10-year life expectancy. And for women who are of average risk in a high resource country like the United States that has mammography available, we recommend, actually, we do not recommend clinical breast exam. Among the women aged 40 to 44, risk of being diagnosed with breast cancer is incredibly low. The odds that a woman who's 40 who wants to get mammography will be helped by that mammogram is incredibly low. Risk of breast cancer goes up as a woman ages, of course, and as I told you earlier, mammography becomes a better test as a woman ages. Actually, when you look at things in 5-year increments, women aged 45 to 49 are actually much more like women aged 50 to 54 in terms of risk and benefit than women aged 40 to 44 are like women aged 45 to 49. And actually, the U.S. Preventive Services Task Force, the U.S. government, came out with guidelines just 2 weeks ago. They recommend, like we at the ACS, against breast self-exam. They, like us, say there's actually insufficient evidence to justify clinical breast exam in a high-resource setting. And for mammography, they recommend individual decision-making for women 40 to 49, whereas we recommend it for women 40 to 44. They recommend every 2-year screening starting at age 50, going to age 74, and we recommend every year for 44 to 54, and the woman's choice of 1 to 2 years from 55 and beyond. And so these are the guidelines that the U.S. Preventive Services Task Force have developed and the American Cancer Society. Big difference, the task force looked at women in 10-year age increments, 30 to 39, 40 to 49. We looked at 5-year increments, 40 to 44, 45 to 49, 50 to 54. Recently, by the way, the British looked at every year, and their new recommendation is that screening start at the age of 47. There's a big, literally there is a big jump in benefit from age 46 to 47. We saw the cut at 45 because we looked at 5-year increments. They saw it at 47. Somebody will come and look at it on a monthly basis eventually, I suspect. But in any event, thank you very much for your attention.
Thank you. Thank you. Thank you, Dr. Brown. We will leave the discussion at the end of the session.
Okay.
It's a distinct pleasure to present our next speaker, who need probably no introduction. All of you have heard about CA 125 and its importance in ovarian cancer. So far, we've been only dealing with it in terms of follow-up of patients and a marker for recurrence. However, very recent data show us that maybe it can be used also for screening, and who better to talk to us other than the man who really has been working it from the get-go. And without further introduction, we'll let Dr. Bass tell us about ovarian cancer.
Over the years, I've thought of AUB as a stargate that transports extraordinarily talented individuals like Jean-Pierre Issa, Agop Kantarjan, Sam Rad to a world stage. Over the last 2 days, I've learned that it's much, much more, not only for Lebanon, but for the entire Arab world. I think if you look at the presidency and the 16th president of AUB, the trustees clearly have chosen wisely. Not only Fadlow's enthusiasm and his leadership and his charisma, but also his understanding of community, of family, and of teamwork. As I listened to Fadlow's talk yesterday, his inaugural, I could only think of Arlie Clark, the extraordinarily successful first president of MD Anderson, who said, "Make no small plans." And clearly, yesterday were not small plans. I think we all will look forward to these next years as AUB assumes an even greater role as a unique community and as a world-class university. This morning, I'd like to focus on one aspect of ovarian cancer management, and that's earlier detection. Ovarian cancer, as many of you know, if it's limited to the ovaries, like many cancers, in stage 1, it can be cured 90% of the time with conventional treatment. Disease that's spread to the pelvis can be cured in only 20% or less. Currently, only about 20% of ovarian cancers are currently diagnosed in stage 1 or 2. Computer analysis has suggested, with modeling, the detection of preclinical disease at an earlier stage could improve survival by 10 to 30%, much greater than anything we can currently manage with the therapies that are available. The challenge for ovarian cancer is that it's neither a common nor a rare disease. Prevalence is about 1 in 2,500 for postmenopausal women. And if you're going to have an effective screening strategy, there's got to be high sensitivity for preclinical diseases you'd expect of any screening strategy. But it has to have an extraordinarily high specificity of 99.6%, even to have 10 operations for each case of ovarian cancer detected. Used alone, neither CA-125 nor transvaginal sonography has adequate specificity. Ovarian cancer is associated, however, with rising CA-125 and benign disease is not. And it's been shown now in several trials, including our own in the UK CTOX, that rising CA-125 not only can give you much better specificity, but also greater sensitivity. The risk of ovarian cancer algorithm is a Bayesian algorithm that determines whether a woman's CA-125 is rising from year to year. The NROS screening trial, coordinated through MD Anderson, used the same algorithm that the UK CTOX used in one of its 3 arms. Here, women who are postmenopause at average risk of developing ovarian cancer have a CA-125 each year. That's analyzed by the ROC algorithm that essentially sets each woman's own normal level, which can be substantially below the normal level for the 97th percentile. If that doesn't change over a year, they come back annually. If it is increased from the previous year significantly, they go into ultrasound and possibly to surgery. If it's somewhere in between, they repeat the CA-125 in 3 months, which is different from previous screening trials. Here you can see some of the outcomes in patients who actually had ovarian cancer, where CA-125 rose abruptly over the year of screening. There are other instances, though, where CA-125 rose within the normal range and still triggered an ultrasound so that you could improve sensitivity substantially. In the NROS trial, coordinated by Karen Liu and myself at MD Anderson, over the last 15 years, we've had nearly 25,000 patient encounters and samples banked from 5,000 postmenopausal women at conventional risk. Less than 1% have been referred for ultrasound after each annual screening, and 2.6% over multiple years, meaning that this would be cost effective. 18 operations were performed by the algorithm, detecting 12 cases of ovarian cancer. 2 were borderline, 10 invasive, with 9 of the 12 in stage 1 or 2. Importantly, no more than 3 operations would be required to detect each case of ovarian cancer using this strategy. A much larger trial to examine survival and mortality was conducted in the UK over the last 14 years in parallel with the trial at MD Anderson, where there were more than 200,000 women. Roughly 100,000 served as controls with conventional care. 50,000 had TV transvaginal sonography each year regardless of CA-125, and the other had an annual CA-125 with the algorithm prompting TVS in less than 2% of cases. With the algorithm, only 3 to 4 operations were required to detect each case of ovarian cancer. About 40% of the cancers found by screening were in stage 1 or 2 as opposed to the 20% that you'd expect. Twice as many ovarian cancers were detected with the algorithm than with an arbitrary cutoff of CA-125. And most recently in December, we learned the final results of this study that excluding the prevalent cases, a 20% reduction in mortality was observed in the CA-125 followed by ultrasound group. Overall, you need to screen 641 subjects to prevent 1 death, and that is going to require more cost-benefit analysis for sure, although in the previous analyses that have been done, this comes out in about the same range as mammograms. Also, the first 7 years, there was very little difference in mortality. It was only after the 7th to the 14th year that you began to see the benefit of this. So if a woman participates in this kind of screening, it's got to be long-term and year by year. With the expectation that this trial might be positive, our own crew at MD Anderson, working collaboratively with a group at Rice, had developed bio-nanochips that actually permit you within 30 to 45 minutes to determine values of CA-125 and other potential biomarkers. So you can imagine a woman walking into a screening center, obtaining a finger stick within 45 minutes, either heading home and planning next year or getting an ultrasound then and there. One of the challenges with CA-125 is that only 80% of cancers express significant levels of the antigen. So there really is a need for additional markers. Our goal over the last decade or more has been to develop a marker panel that detects at least 90% of early stage disease. We've evaluated 110 biomarkers. 2 of those don't actually go up before CA-125, but they do detect about 18% of the patients missed by CA-125 at the time of conventional diagnosis. One other option, though, was to look at autoantibodies to antigens that are expressed by ovarian cancers. Overall, about all high-grade serous ovarian cancers and about 2/3 of ovarian cancers have mutation and overexpression of p53. A more sensitive technique that goes up before CA-125 would be really important because at present time, our understanding of the pathophysiology of ovarian cancer is changing. Perhaps as many as 1/3 of all of the cases, and particularly the hereditary cases of ovarian cancer, are probably not from the ovary, but rather from the fimbria, the fallopian tube. And recalling your anatomy, anything that falls off of the fallopian tube goes directly into the abdominal cavity. So as soon as a cancer cell can avoid anoecus, it can set up shop and develop metastases. We've actually studied 3 groups of patients from the US, from Australia, and from the UK using a microassay for autoantibodies that the patient has made herself against her p53 in her ovarian cancer. In each case, from 21 to 26% of the patients at the time of conventional diagnosis had an elevated titer of autoantibodies. And this seemed to be true both for patients in early stage and for patients in late stage. Probably the most exciting thing that's come out of this study is that you can see an elevation of the autoantibodies against p53 long before you see an elevation of CA-125. In some cases, this can be as long as 3 or 4 years with a progressively rising titer as the disease develops further. think the implications looking forward are first from the UKC tox and from our own study that at least we're on the right track. The challenge is going to be to try to develop a panel of biomarkers, probably a panel of autoantibodies in addition to CA125, that are going to pick up the cases you'd miss by CA125 and ideally do that at an even earlier interval. Also, there's tremendous need for better imaging. If you use this ultrasound as an imager, you don't see fallopian tubes. And currently, we're working with a SQUID quantum interference detector that may be an order of magnitude or 2 orders of magnitude more sensitive than conventional imaging. These are things for the future. I think our challenge at the moment is to figure out what to do with the UK CTOX data, whether we go through conventional approval through the FDA and Preventive Health Services Task Force, or think about possible marketing. I'd vote for the former, but already in the U.S., there are at least 4 different states have a laboratory-developed test for this with the algorithm. We've recently had at least one example with the Oncotype DX for breast cancer, where a laboratory-developed test has actually been developed legitimately and I think with great benefit. Remains to be seen whether that could be a route for the CA125 algorithm as well. Thank you.
Thank you.
Thank you. When we were preparing for this cancer symposium, Fadlo did not even ask me, who do you want for the breast session? He said, it's Ruth. Ruth O'Regan, Dr. Ruth O'Regan, very well known to us, international recognized breast cancer physician and expert. She will talk to us about new paradigms on targeted therapy in breast cancer.
Well, thank you very much, and again, thank you so much for inviting me. So, Najee gave me a very tiny topic to cover in a short time, so I'll try and just hit a few highlights here. And just for the non-oncologists in the audience, we've been talking a lot about targeted cancer therapy today. And just in terms of what we mean about that is that what we're trying to do is find a target that's either only present on the cancer or expressed in high amounts on a cancer so that you can develop a drug against that target on the cancer, which will allow greater efficacy of the agent that you're going to use. But because the target is not on normal cells, it will decrease the type of toxicity that you see. So that's kind of what we're talking about when we talk about targeted therapy. So as far as breast cancer, just like Ram was talking about lung cancer earlier, there are several types of breast cancer, and we've known that for decades. But what really kind of hit that home was this really pivotal data that showed that if you look at a set of genes in patients with breast cancer, you're able to subdivide them into 3 or 4 different subtypes. So this is a heat map shown here, and what you're looking at is these genes shown down on this axis. Where it shows red, it means the gene's overexpressed. Where it shows green, it means the gene is underexpressed. And when you do this with a group of breast cancers, what you find is that they cluster into these different subtypes. These 2 here are estrogen receptor positive, which I'll talk about in a second. This is a HER2 positive subtype, and this is a basal or triple negative subtype. And what you're looking at over here is that when you look at time to distant recurrence or overall survival, they have very different patterns of recurrence and survival, as you can see shown here. Not going to go into a lot of detail with this, but as you can imagine, because these cancers differ in the genes that they express, obviously they all probably need different types of treatment. So first of all, I just want to talk about estrogen receptor positive breast cancer. And there are 2 types of these, the luminal A and the luminal B, which are actually quite radically different in their behavior and I think with the treatment that they're going to require. When we talk about targeted therapy for breast cancer has been ahead of the game because we did have a target that was identified back in the 1930s in the University of Chicago, and that is the estrogen receptor. This is the crystal structure shown here, and here's the receptor itself shown over here. After the estrogen receptor was discovered, the drug tamoxifen was developed actually at University of Wisconsin and really revolutionized the treatment for patients with estrogen receptor positive breast cancer. So I know this is quite small here. You'll have to trust me, but you can see the tamoxifen is improving outcome for these patients with early stage breast cancer. And subsequent to this, we had a number of other agents that were approved, including aromatase inhibitors and also the estrogen receptor downregulator, fulvestrant. And all of these drugs have improved outcome for patients with estrogen receptor positive breast cancer. Now, up until about maybe 10 years or so ago, even though we knew that the endocrine agents like tamoxifen were effective in these estrogen receptor positive breast cancers, being medical oncologists, we felt that everybody was going to benefit from chemotherapy as well. Even though we knew that if you looked at patients with estrogen receptor positive breast cancer, the benefit of chemotherapy was quite small. So we needed to develop an assay that would tell us which of these patients needed chemotherapy on top of endocrine therapy. And the 21 gene recurrence score that was just mentioned by Dr. Bast really gave us this information. And what this is it's basically an assay that looks at 21 genes in an individual ER-positive breast cancer. It gives you prognostic information, but most importantly, it tells you which patients are going to benefit from chemotherapy. And if you have a low score using this 21 gene assay, there is no benefit from chemotherapy at all. And this is a really important test because we've been using it now for about a decade or so. There's probably more than 500,000, it's probably much higher than that. Women have been basically, chemotherapy has been omitted from their treatment plan with all its toxicities because of using this test. So that's been very important going forward. Now, HER2 positive breast cancer. This was a very interesting subtype of breast cancer. The HER2 gene was discovered back in the 1990s, 1980s, and it was associated with a very, very aggressive form of breast cancer that had a very high rate of metastasis over the first 2 to 5 years following diagnosis. So it was really one of the poorest prognostic breast cancers out there, and it makes up about 25 to a third of breast cancers or so. Thankfully, however, at the time, right after the HER2 receptor was discovered, the drug trastuzumab, or Herceptin, was developed, which is shown here. It's a humanized antibody that targets this HER2 protein that's found on the surface of the cell, which you can't really see down here. So this antibody really has revolutionized the treatment of these cancers. This is the pivotal initial data that looked at the addition of trastuzumab to chemotherapy in patients with HER2-positive breast cancer, showing a highly significant survival advantage in the patients who got the trastuzumab plus chemotherapy compared to the chemotherapy alone. The interesting thing about this study is that at the time that trastuzumab came down the pipeline, we weren't really doing much targeted therapeutics in breast cancer. And in fact, when a new drug came along, what we would do is just give it to everybody with breast cancer. But Dennis Slayman, who was responsible for developing this drug, worked very hard so that it was only used in cancers, in women with cancers that express the HER2 receptor. And if he hadn't done that, we know from a subsequent study that was done, we wouldn't have this drug now. And just to show you how impactful this drug has been, this is where you, for patients with early stage small cancers, where you give trastuzumab with just paclitaxel for 12 weeks and then continue the trastuzumab for a year. And this is, if you look at this, is the relapse rate in these patients, which at 3 years is about 2%. So basically, the use of this drug is actually allowing us to cure patients with this highly aggressive form of breast cancer. We now have some other agents, some other antibodies that when you add them to trastuzumab even further impact outcome for patients. This is the Cleopatra study that looked at pertuzumab added in with trastuzumab plus chemotherapy. And this is a very interesting agent called TDM1, which is trastuzumab with a chemotherapy moiety attached to it, which also has been shown to be very effective in these patients. So I'm not sure you can do much better than this, but certainly with these new agents, these patients are really doing very well. So what's the problem here? Well, the problem is that we're still losing about 40,000 patients annually in the United States to breast cancer. And why is this? Well, the idea of resistance to the agents that we have is probably mainly one of the explanations for this. So this is basically just to show for the non-oncologists here that just like bacteria, when you expose them to antibiotics, they can become these superbugs where they're essentially resistant to all different types of antibiotics. Well, the same thing happens with the targeted agents that we use for breast cancer and other cancers, such that what happens is that you may be targeting a specific protein in the cell, but as the cancer cell kind of gets used to being exposed to this targeted agent, they develop resistance mechanisms, which basically mean the drugs aren't working anymore. And one of the best studies of this is resistance to endocrine therapy like tamoxifen. And sorry, this is a very busy diagram, but one of the things we know that happens as you develop resistance to endocrine therapy is that estrogen receptor no longer becomes a viable target for these drugs. And part of what happens is other proteins start driving the cell, which is what we're looking at here essentially. One of them indeed is HER2 that I just mentioned, but also some other growth factors upstream on the cell surface. Well, all of these proteins actually signal eventually through a protein called mTOR, or mammalian target of rapamycin. And the good news for this is we have agents that target this protein. So in patients who have cancers, metastatic cancers that are estrogen receptor positive but resistant to endocrine therapy, what we know is by using an mTOR inhibitor, you can improve outcome for these patients by targeting this particular protein and presumably allowing the estrogen receptor now to become a viable target. And this study led to the approval of everolimus in patients with ER-positive cancers who develop resistance to prior endocrine therapy. Another drug just to mention is CDK, which lies in the nucleus, is involved in cell division. And a study basically looked at an inhibitor of CDK in patients with ER-positive endocrine-resistant breast cancers and showed a significant improvement in outcome as well. So within the last 2 or 3 years, we have 2 new agents which were developed specifically for these cancers in which endocrine therapy no longer works. And then lastly, just to end talking about triple-negative breast cancer, which is the one that's by far the hardest to treat for us. Triple-negative breast cancer is characterized by, as you can imagine, a lack of estrogen receptor, a lack of HER2, and a lack of the other endocrine target, progesterone receptor. In the US, they make up about 15 to 20% of the breast cancers we see, but they do have a prevalence to occur in certain ethnic groups, including African Americans, Latinas, but also young women. So this is some data that we did in Atlanta, basically showing that if you look at patients under the age of 55, whether you're African American or Caucasian, if you're under 35, your risk of triple-negative breast cancer is very high. But once you get to the age of 35, it drops off quite a bit in the Caucasian women, but does not drop off in the African American women. Now, why do they have such a poor outcome? Well, first of all, if you look at the outcome shown here, what you can see is that they have a very, very high rate of relapse within the first 2 to 5 years. And their survival shown here is really very poor. It's one of the poorest prognostic breast cancers that we have. Now, there's really 2 reasons for that. The first one is that we don't have any targeted agents for triple-negative breast cancer as yet, which I'll show you in the next slide. But the other thing is that these cancers are kind of paradoxical because they can be very sensitive to chemotherapy, in which case they actually have quite a favorable outcome, which is shown here. But the majority of them are resistant to chemotherapy, and that's the only approved therapy we have for triple-negative breast cancer right now. And if they are chemo-resistant, unfortunately, their prognosis is really very poor. We don't really understand the chemo-resistance mechanisms that exist in triple-negative breast cancer, but that is a really significant problem with these type of breast cancers. To make matters even more confusing, we know, and we've known for years that triple-negative breast cancer is an umbrella term. And this is some work from the Vanderbilt group where, again, they looked at a number of genes shown here, and they were able to show that, in fact, there are about 6 or 7 different types of triple-negative breast cancers that are all unique in the way they behave, and of course then will require different therapeutic approaches. And this is kind of the way forward for triple-negative breast cancer, is looking at these different subtypes and kind of working out how we should treat all of them. There is some reasonably encouraging data with immunotherapy that Dr. Bunn talked about in triple-negative breast cancer. In fact, for whatever reason, it's the only type of breast cancer that appears to benefit from this. This is basically just showing that with single-agent pembrolizumab, you can see some quite nice responses in patients with triple-negative breast cancer. And there is one of the subtypes that is driven by immune processes, so that might be the one that's benefiting. Then there's also a very interesting one that actually expresses the androgen receptor, which is a protein that we find in prostate cancer. And there's been several studies looking at using anti-androgen or prostate cancer therapy in patients with this form of triple-negative breast cancer, which shows that this is a viable approach and probably needs to be more selective in which of the triple-negative breast cancers get this approach. And also, there may be a role for adding in some of the agents I talked about, like the CDK inhibitor and mTOR inhibitor, along with anti-androgens to improve outcome for these patients. And then there's a type that's kind of more like sarcomas, which are mesenchymal. And we've done some work basically showing that if you inhibit FAC, you may be able to reduce invasion of these mesenchymal triple-negative breast cancers. And hopefully, if we confirm this in animal studies, we can take this into a clinical trial. So going back to our target, I think where we are for breast cancer right now is probably out in the periphery here. I think for all cancers, we want to be around the center here where we really have a truly targeted therapy that only affects the cancer cells and doesn't affect the normal tissues. And I think we'll get there with further clinical trials and further research. Thank you very much for your attention.
Thank you. We're going to start our coffee break at 11, so we have a few minutes for question. Can our speakers please drop in? And if I may start with just a question on for both of Dr. Browley and Dr. Bast. Now, it's one thing to put a screening trial and then to move this trial into the public. And I think it's nice to review a mammogram in a trial, but it's not the same thing when you put this mammogram in a community hospital or in a small dispensary where, you know, you look at this mammogram, you really don't see anything. And the same thing with ultrasound. You do this ultrasound with the UKC talk in these centers, but you have to come to our clinic in a small dispensary with a $5,000 ultrasound where you really don't see the ovary in almost 40% of these postmenopausal women. So how can you move these, you know, these trial into the clinics?
The epidemiologist would say that there is such a thing as efficacy and there's such a thing as effectiveness. Most of our clinical trials measure efficacy, which is how does the drug work or how does the screening test work when things are maximized. The lung cancer screening trial that Ram talked about earlier was in 33 of the finest hospitals in the United States using some of the finest radiologists. And we had a 20% decrease in risk of death, but we had 40% of people having false positives. How will that translate when the study, when that same screening test is done in non-academic centers? That is effectiveness. How does it work in the real world? And unfortunately, there is a drop from an efficacy trial to effectiveness. Some people have said that we should do very large studies in the community with people, with real people instead of people who are healthy enough to go on the clinical trials. Others say that we should do the efficacy studies and then do phase 4 follow-up studies to look and see what the effect actually is in the community. But your point is well taken.
In the case of the ovarian screening strategy that I just described, there are several issues, but certainly one of them deals with interpreting the algorithm for CA-125. And although I mentioned in the United States, as many of you may be aware, there are two ways to actually market tests for anything. One is by laboratory determined developed tests, or LDTs, and these are affectionately known as home brews. Some are less home brew than others. For example, we were talked about the Oncotype DX having been very responsibly developed, I suspect, you know, like the UK CTOX study. But one of the advantages of an LDT is that it all comes to one laboratory. And in terms of interpreting the algorithm and working out the nuances of CA-125 going up or down every 3 months, to have that come to one place for interpretation makes some sense. The other issue is really about the imaging. And in the UK CTOX trial, in the interest of time, I didn't go into all the details, but that was actually conducted at 13 centers around the UK. And there was careful regulation and education regarding the ultrasound. But I think, and hopefully one could identify other chemical tests that could be used in a confirmatory way. One of the challenges, particularly if you've got fallopian tube cancer, is that CA-125 keeps going up and the ultrasound's still negative. These confirmatory studies, like we were talking about with the squid assays, would have to be done probably at a regional center. But you could imagine something, if the CA-125 kept going up in a community practice, you could refer to a university center, at least in the United States, which might help with that. In the UK, they actually manage the quality control quite well. And in spots like Lebanon, I would think if you instituted this, if much of this was done here at AUB, you could manage the quality control quite well.
Dr. Browley, I want to bring up one issue about the self-exam and clinical breast exam. We have not dropped it here. We still bring it up in all our awareness campaigns, and I believe strongly we should keep it because in all low middle income countries, we still see lots of locally advanced breast cancers. Many countries see 60 to 80% locally advanced and metastatic at presentation. In Lebanon, at least data from AUB, we brought it down now to 35%. We still see about 35% at presentation advanced disease. So we still think self-exam and breast exam has a role in that.
Okay. In terms of clinical breast exam, I'm in agreement with you, and indeed we took very great pains, and I tried to stress it in my talk, that our recommendation against clinical breast exam is a recommendation really for the United States. And it's not really a recommendation against clinical breast exam. It's a recommendation against doing it and telling the woman there's clear evidence that it saves lives. Again, it's not a recommendation against doing it. It's a recommendation against doing it because of or in telling people that there's clear evidence that it saves lives. Those studies have not been done.
Thank you.
In terms of breast self-exam, there's a lot of confusion. The recommendation is against the monthly breast self-exam, which is something that was created by the American Cancer Society in the 1950s, and it encouraged women to spend 45 minutes examining their breasts once per month. We do recommend that women be aware of their breasts. Indeed, a large number of breast cancers in the United States are currently diagnosed when women are getting dressed or in the shower and feel something and say, what is this? And we want to encourage women who find those things to go get them checked out.
Thank you. We have a question in the back.
Thank you for this informative presentation. Actually, my question or comment also goes about the new recommendations for breast cancer screening. So how comfortable are we to extrapolate these new guidelines in our societies? The median age for breast cancer in the US is 63, and the median age in Lebanon and other Arab countries is anywhere between 48 to 51 years. So we're talking about a totally different population. Is it because of a different demographic pyramid? We have cancers earlier. Whatever it is, how comfortable are we really to adopt these recommendation? And again, the other point is women, we have, Dr. Saghir can talk more about this, we have mammograms, we have campaigns, but still screening mammograms are underutilized. Women are scared to talk about breast cancer, to examine their breast. So we think in this society it's still important to empower them to do the breast exam so that, you know, part of this fear is broken. And again, there is no system where radiologists communicate findings to patients. So it's still important to go to the physician for a clinical breast exam where they check the results. We always get patients with missed positive findings because follow-up is not perfect in many of the country's institutions.
Well, the first question, I am very hesitant to apply American epidemiology in another country. I'm very hesitant. Number two, I think I said in my talk, we do need a good screening test for younger women. The problem is mammography is not that test. I've been very outspoken in the United States. We have spent a lot of time and a lot of resources in the United States on screening younger women when we should have spent some of that time and some of that resources in developing a test that actually works. Indeed, if you look at the United States, the cost of screening women age 40 to 45 in the United States, not even age 40 to 49, is $5 billion per year. If you look at the U.S. investment in research for all cancer, it is $5.2 billion per year. So we're spending almost as much money screening women 40 to 44, and I wonder if it works as we're spending on all cancer research, not just breast cancer, all cancer research.
Thank you. We need to, I was told by the organizer, we need to stop. The speakers are ready to answer your question. We're going for a coffee break and coming back in about 15 minutes. Thank you.
Well, my other favorite is the Department of Defense on bands and music is $600 million last year. The